All right, guys, it is now 1 o'clock. Today is Monday, the 3rd of August. Today starts in lab. Students will be going over to lab first part of the day and then coming over to finish up RT 210B. We're going to finish up with the cardiovascular diseases on the left side and right side of the heart, some of the diseases of the arteries and diseases of the veins. Okay, and after that, which will be quickly, after that we will finish up with a review of the whole section, go over some practice EKGs, strips, and review for the day. After that, tomorrow will be the exam. So now I'm going to pause the recording so that the students can fulfill the laboratory requirements, which is at 1 o'clock. Again, if you don't get a chance to come, you'll need to contact Mr. Boyd and find out when he's holding his makeup lab sessions, all right? I will come back to this recording after the lab is complete and we'll commence for the day, all right? Okay, guys, just was informed that the lab instructor is under the weather this morning. So what we're gonna do is go ahead and knock out the rest of the lecture, which is just a little bit left. We're gonna talk about the diseases of the heart, either the right side or the left side, and then we will review the whole RT 210, do some review, some question, call and answer, and then finish up in the lab. I don't know a specific time. Whenever I get done with this and make sure everything is solid, then we'll go over to the lab and check the students off on heart rate, respiratory rate, blood pressure, okay? Those that borrowed cuffs from Mr. Boyd needs to make sure you have them. Should be 8 total coming back so that we can do them, okay? So that's not gonna be anything I have to show you. That's already been taken care of. You will be checked off on that, okay? Then I will show you EKG leads. We'll talk about that a little bit. It's simple, just knowing where to put the leads and how to turn on the machine and the proper ways to do that, okay? And that will be your EKG checkoff. All right, so let's go ahead and get started with the lecture. Again, we started off with, we left off with atrial rhythms and ventricular rhythms. We talked about which one of those are you cold? Okay. We talked about which one of those, it's got chilly all of a sudden, are deadly or not. I know you always cold. You can close that door if you want to, if you're cold. Okay. Yes, so we talked about atrial rhythms and we talked about ventricular rhythms. Now, I'm sorry that the time got thrown off. I was not aware that he was not feeling well, but either way it went, you're either online or here at the school. I only have 3 students here at the school. If it was a lab checkoff this morning, only 3 people will be here to do it. Okay, there's 119, only 3 students are here. Okay, I don't have anybody at this time, 20 after 1, logged in to the lecture. Okay, so it is being recorded. You guys will have to go back and look at it and study it. Make sure that all your programs and your systems are running good, because when, there's a lot of things going on. If it's clear on my end, if your end is unclear or anything like that, you need to very quickly check out what's going on with your system, because if you're not here, this is the only other means for you to get it, okay? So if your Wi-Fi at home or your computer is updating, all these different things that are going on, it's nothing we can do about that. We can give you the lecture, record it for you as crystal clear as possible, or give you the opportunity to be here in person, okay? If you can't do either one of those, then it's nothing that we can do but to help you during tutoring times and thus forth. Now, speaking of tutoring, I will be out of town tomorrow. Let's just say I should be able to log in around 11-ish. I have to go out of town and I will be in court, okay, in East Tennessee. I'm leaving tonight. So court is at 9 in the morning, but they're an hour ahead of us. So I should be done by that time. If not, just show that you tried to log in and we'll get you logged in later on that evening. But we will do definitely class tomorrow from 1 to 6. I'll be holding class from my hotel in East Tennessee. All right, so that's nothing's going to stop class. So I may not be able to do the tutoring part, but I will be able to have class at least by 1 o'clock. Okay, don't forget that the test is tomorrow. Don't forget all of your proctoring requirements. Your computer and all of that stuff needs to be on point for the test. Nobody can take the test if I can't see you. If I can't see you and your hands and all those things, then you cannot take the exam. Okay, so let's get started, and we'll go from there. Question? He's not here. He's not feeling well. I just found out he's not feeling well. So we're going to do the lecture first, and at the end of the day, I'll finish up the labs. All right. So we left off yesterday with atrial rhythms and ventricular rhythms, right? Atrial rhythms and ventricular rhythms. We talked about there's some atrial rhythms, like A flutter, right? A fibrillation, right? Sometimes you have PACs, which are premature atrial contractions, which you'll have little P waves that pop out of nowhere, okay? Little P wave, because we said the P wave was atrial depolarization, or AKA atrial squeeze, right? And then we learned that we also have some ventricular rhythms. We have some ventricular rhythms that are having a problem, right? Yes, ma'am. As soon as I get through with this, because I don't have much left. All I got to do is finish the diseases, and I was going to do a review for everybody, have a good, strong review, and at the end of the day, I was going to go over there and check y'all off. Okay? If you can't check off, if you can't stay, then we'll have to make it up. You're not going to get a 0 for it. You just have to make it up. Okay? I was just told this morning that he wasn't feeling well. I was sitting here thinking that he was going to pop up any moment, and he didn't. Nobody told me, so I just found out. So now, yeah. Well, I'm going to do this. I'm going to do this. I can't tell you exactly because I hate to throw you off, but I want to make sure I get all of this done. Like I said, only thing left is the diseases, cardiac diseases, and then review. There's some EKG practice I'm going to put up on to practice the rhythms, and then we'll do it. So let's just say, let's shoot for 4 o'clock in the lab. Huh? Okay. Oh, okay. Yeah, no, make it. Yeah, I don't know his makeup times, but yeah, if you can make it up, because I should be done around 3:30ish, but if you got to be that way, you'll be rushing trying to leave her to go to work. So I mean, you can just make it up. Well, I'm sorry about that. I just found out myself. Okay. All right. So we talked about atrial rhythms and ventricular rhythm. The ventricular rhythms are the ones that are deadly. Okay, there are some of them that are deadly. What are the 4 ventricular deadly rhythms? PEA, which is pulseless electrical activity. It means you see a nice rhythm, but there's no pulse. When you check the pulse, there's no pulse, right? So V field, V tach, and simply asystole. No rhythm at all, right? Just flat line, okay? No rhythm at all, which is a flat line, okay? So those are your, make sure you know your 4 deadly arrhythmias. Make sure you know those for the exam. The 4 deadly rhythms are PEA, also known as EMD, your V tach, V field, and asystole. ASYTOLE, I think. Asystole. All right. Now, so that was the end of that. That's make sure. I'm hoping that you guys studied that. You know your rhythms when you see them. In the book shows you the rhythms very, very plainly. The chapter outlines what you're looking for, what the P wave, the T wave, the QRSR represent, right? So that is on you guys to have learned that, all right, to have studied that. Now, today we will do some practice interpretation. I got a little website and I'm gonna pop it up on the screen. It's gonna be a rhythm, and you're gonna tell me, we'll choose together out of the 4 or 5 choices which one that is. Okay, so help you understand a rhythm when you see it. Okay, I don't even remember all of the rhythms 100%. If I see one, it could be something I thought it was this and it's something else. So we'll ration out between that. Okay, because you're not gonna have to know every single rhythm there is. Okay, you're not cardiologists. You're just looking at some of the basic rhythms, introductory rhythms into respiratory therapy, which will be more advanced as you go on. Okay, as we go on. All right. So let me share my screen with the rest of the lesson plan. The actual diseases of the heart. Cardiovascular diseases. Here they are. Cardiovascular diseases. Now keep in mind that we have some diseases that are indicative of the right side of the heart and some that are indicative of the left side of the heart, right? Remember, the right side is the pulmonary side, okay? Right side is the pulmonary circulation on the right. That's the right, that's the lung side, right? Pulmonary side. Anything that's wrong on the right side of the heart is a pulmonary issue, okay? That's the pulmonary circulation. Everything on the right side of the heart is for pushing blood to the what? To the lungs. That's what the right side of the heart is responsible for. The right side does not care what the left side is doing. The right side is only concerned with pushing blood to the lungs and getting it back from the body, okay? That is the pulmonary circulation side. The left side is systemic. Systemic, let's just say, AKA, where does this blood go? To the body. AKA the body. That is the left side. The left side does not care what the right side is doing. The left side only cares about blood getting to the body, returning from the lungs and going to the body. That's what the red side or the left side. Okay? Don't forget our colors. On the right side, the reason why you see blue is because it is deoxygenated, right? That is the used up blood and that has a low oxygen content, right? It's deoxygenated and it is going to the right side of the heart in order to get to the lungs to pick up oxygen. Once it leaves the lungs and comes back to the heart, it comes back on the left side, which is the systemic circulation. The left side is responsible for pumping bright, oxygen-rich blood to the body. Okay? All that is happening with every beat of your heart. The atria contract at the same time, the ventricles contract at the same time. When it happens, on the right side, the ventricle is pushing it to the pulmonary artery to the lungs. On the left side, that blood that has returned is being pushed through the aorta to the body. Every beat of your heart. Okay? Now, a quick review. Everybody look on the board, even though they're at home. Blood returns to the body. Everybody look up here. Blood returns to the body via the superior and inferior what? Vena cava. Dumps into the right atrium, goes through the tricuspid valve into the right ventricle. Then it goes through the pulmonary valve or pulmonic valve, either one, into the, now notice how the pulmonary artery splits off both ways, right? Because you got a right side and the left side heart, lung, right? So it's going to the left lung over here, right lung over here. Then it goes to the lungs, okay? After it returns from the lung, it returns via the pulmonary veins on both sides, right? Comes back from the lung, but they both dump into the left atrium, go through the bicuspid or mitral valve, down into the left ventricle, then through the aortic valve into the aorta and then to the body. Up here are your common carotids. You have, I think these two are your common carotids. They go to your carotid artery, go through your neck, from your heart, straight up here, okay? And that's why if you get your, if somebody gets your throat slit, you bleed to death instantly because that's your aorta blood going to your brain. Everything stops. Blood pressure drops, okay? All right. So sometimes this stuff does not perform correctly, okay? Sometimes there's issues or disease process that cause the lung or the heart not to process correctly, okay? It causes the heart not to function correctly. If there's a problem on the right side, it's called cor pulmonale. Right-sided heart failure is also known as cor pulmonale. Cor pulmonale. All right? You also have some congenital abnormalities. Now look, when you're a baby, sometimes some small babies are born, everybody look up here, what's called transposition of the great vessels. These are the two great vessels of the heart, pulmonary artery and the aorta. Those are the two great vessels, right? They're big. Sometimes babies are born with these in the wrong place, right? So the aorta is hooked to the right ventricle and the pulmonary artery is hooked to the left ventricle. It's switched. So the baby's not getting no oxygen, right? Because all the good oxygen going back to the lungs again. Going back to the lungs. And deoxygenated blood is going to the body. That right ventricle is pumping to the aorta to the body. That's a transposition of the great vessels. You'll learn that when you guys get into peds, okay? That's one of your neonatal ICU peds information, right? Some heart defect is called congenital. You're born that way. So the doctor can go in and surgically reverse them and you'll be fine, okay? Open heart surgery on a newborn baby. What happened if this is the problem, okay? What happened if this is a problem? All right, so that's why it's important to know which side is which, okay? Because you have issues like that. All right, so let's look at the left side of the heart, which where your information starts on the PowerPoint. The left side of the heart. Left side diseases will be high blood pressure, which is hypertension, cardiac pulmonary edema. That means you have fluid in your lungs because the heart ain't doing its job, right? Everybody look up here, because you're going to be time to write it down. If blood returns to the heart via the pulmonary veins, right? Returning to the heart. What if the left atria is not pumping like it's supposed to? Then the blood is trying to get into the left atrium is becoming what? Backed up. It's a backup. And if it backs up from the pulmonary vein, it's going to go back up into the, where's it coming from? The lungs. The pulmonary veins is the blood coming back from the lungs, right? So if the pressure becomes too high in the left atrium, or if this mitral valve is not working properly, not opening up like it's supposed to, blood is going to back up. And if it backs up from here, backs up through here, it's going to come here and go into the lungs. So then you'll see that in the x-ray, it just looks like a lot of fluid around the heart. That's called congestive heart failure, because the left ventricle is not pumping like it should, right? So if that left ventricle ain't pumping, it's not keeping up with the demand. The blood saying, I'm trying to get to the body. So I don't care what you do, left ventricle, you just need to get me there. But if the left ventricle's engine ain't working right, then I'm gonna be waiting. I'm gonna be backed up. Look around, the line gonna be super long, right? Because the door stopped opening. If everybody in here lined up at that door and I open up the door, let you out, open up the door, let you out. But if I stop and shut the door, then everybody's backing up, right? The line starts backing up. Well, the fluid starts to back up into the lungs. And you can see that as a haze around the heart. That's congestive heart failure. That comes, number one, from cocaine use. Cocaine use can really kick in congestive heart failure. Anybody snorts cocaine or uses cocaine, 9 out of 10 times, they're going to end up with CHF. Also, somebody who, like me, who has hypertension, if I don't control my hypertension and stop eating the salt, get the weight down, I can end up with congestive heart failure. Okay? And that also leads to the cardiac pulmonary edema, because if I have CHF, that means this is not working right. I'm starting to back up, right? Blood is coming back into the lungs because it's getting backed up. That is cardiac pulmonary edema. That's the lungs is full of fluid because of the heart. There's another kind of pulmonary edema that doesn't have nothing to do with the heart. You'll learn that in the last lesson that we have in RT2 team. Okay? So there's some cardiac pulmonary edema and there's some non-cardiac pulmonary edema. Okay? Like say if you went somewhere and inhaled some ammonia gas and your alveoli capillary walls start melting, right? Then you start filling up with fluid. That's got nothing to do with the heart, does it? But you still have pulmonary edema because of something else. Okay, so there's cardiac and non-cardiac pulmonary edema. But right here, left side diseases, hypertension, cardiac pulmonary edema, CHF, and MI. What's an MI? Myocardial infarction, which is AKA heart attack. AKA heart attack. If you have a heart attack, the left side issue, you have had blood flow to the heart has been ischemic or ischemia. Everybody look up here once again. You see these blue and red vessels on the heart? You got a blue one and a red one. See them? All right. You have a blue and a red one. That's your coronary artery and coronary vein. Okay. Which one you think is the coronary vein? The blue one. Okay. The coronary vein is the one that takes deoxygenated blood that the heart uses. The heart got to use blood too, right? The heart all this time is such a non-selfish organ. It pushes blood where it needs to go. But it's a muscle, the most important muscle in your whole body. So it has to metabolize as well. It has waste and it needs oxygen. So you have the coronary vein taking blood from the heart and throws it into the circulation. That coronary vein will send that to the pulmonary artery and into the lungs to come back, right? Then you have the coronary artery, right? Oxygenated blood that went from the left atrium to the right ventricle will then be pushed to the aorta, but some of it goes to the coronary artery to supply the heart with blood. The heart needs fresh oxygenated blood as well, right? So sometimes you have diseases of the vessels, like chitlins. You ever seen chitlins that they sit in a pot overnight? It looks like wax. Well, that's fat. When you have atherosclerosis, you have fat in your arteries, okay? That fat in your arteries starts to block the blood flow. The blockage of blood flow, what's that word called when we have blockage of blood to an area? It's in your vocabulary. Ischemia. Ischemia. Anytime you have blockage of blood to an area, it's called ischemia. Once the heart does not have that blood, it attacks you. It dies. And when it dies, that's what you feel as a heart attack. That little piece of your ventricle that didn't get that blood flow dies, okay? So look up here. Ischemia is a term that means lack of blood flow to an area. That's called ischemia. You can have an ischemic heart attack or you can have an ischemic stroke. If you get lack of blood flow to the brain, you have a stroke. Lack of blood flow to the heart is a heart attack. Lack of blood flow to your arm, you cut it off, right? It dies. So anything that has ischemia is a blockage of blood to that area. If you have ischemia to an area, eventually that area is going to become necrotic. What does necrotic mean? What does necrotic mean? Necrosis. If something is necrotic, what does that mean? Might not be on that sheet that it's in this man's some of the stuff you might not have, but some of the stuff you should probably have heard by now. What does necrotic mean? Necrosis means dead. When you have necrotic tissue, that's dead tissue. So if the life blood, which the life fluid of the body, which is the blood, does not reach an area, that area starts to die. Okay? So what causes it not to get there? What's the term? What did I say the term is when you have lack of blood flow to an area? Ischemia. Okay? You have ischemia. And if you don't fix the ischemia, you will then lead to what? Necrosis of that tissue. Okay? Necrosis of that tissue. So it looks like this. Say you have an artery, right, full of good old blood, and it's coming to this tissue, right? This is just say this is your muscle, right? That's your muscle, and it's living, no problem. You got blood going to it. But if something happens and I get a blockage, if I get a blockage in my artery, then the blood stops flowing. That blockage is ischemia. It's not flowing because of whatever, either the fat, the grease, calcium deposits, whatever it is, it stops my blood from getting to my tissue, my muscle tissue. Once the blood stops flowing, then this muscle starts to die. Once that muscle dies, you get a heart jerk. That's a heart attack. That's where your heart attack comes from. You have, that's why people get stents. You ever heard of stents? Somebody had to get a stent in their heart, a cabbage, right? Bypass surgery, because one of those arteries has become completely occluded. So we have to go in and make a new path. Take the old one out and reroute the blood to that tissue. That's called bypassing the clot. So instead of this clot causing you to die, what we do is we just cut it right here and then bring the blood a new way. Use another artery or vessel to use the blood to now bypass that blockage and get into the tissue. Okay? Yeah. Just that means 2 or 3 of them blocked. 2 or 3 areas that are blocked. Yeah, you only have one carotid artery. You know what I mean? Coronary artery, but it branches off and does different things. And if it's blocked off in several places, you have a triple bypass, double bypass, or a single bypass. Okay? How many times you have to reroute? So if, for instance, if it was a blockage here and I had to reroute this one, and then say this part was blocked, and then we found out that this one was blocked, right? And what they do is that angiogram where they squirt dye into your femoral artery, okay? They squirt dye in there and they put you on this like a x-ray, a live x-ray, moving x-ray. They can see the heart doing its thing, and they can see the dye, right? And they trace the dye. If the dye stops, that's where the blockage is. They know exactly where to go in and reroute, okay? So that causes a heart attack. Sometimes it's such a massive that it kills you, and sometimes it's small, right? Small heart attack. Sometimes you might not even know me, okay? You might not even know me.
So can you not know that's a heart attack and just die like right there?
You don't know because you're going to feel it. Now, if you had like, my chest was, I thought it was gas. You look at it later, it could have been a heart attack. Mild, right? But you're going to feel something. You're not going to just be walking and just boom. Then you're going to, ooh, and then die, okay? Yeah, there's signs. Yeah, it depends. It just depends. Like if it's impending, you know, it's building up, you know, or it could just be so massive that you just and fall out. The pain is just so much you fall out. But sometimes you get diarrhea. Somebody starts sweating real bad. They can have nausea, back pain. Their jaw could be hurting. Hands start chest hurting and radiate down an arm, right? Stuff like that, because that's just the blockage of that blood. That's all those arteries in the body. Okay, so that is the left side issues. Those are systemic. Okay, hypertension, cardiac pulmonary edema, CHF, and heart attack, MI. All right, so let's look at them on here. What causes these cardiovascular diseases? So number 1, hypertension is caused by high pressure in the cardiovascular system. High pressure in that system. That's what you guys practiced on Friday, checking each other's blood pressure. How much pressure is it taking to push blood through the body. It should be 120 over 80 millimeters of mercury. That's the pressure that should be normal. But for some people, it's far higher than that, right? Which can cause aneurysm. That little aneurysm you're gonna find out is when a vessel bursts, right? You're gonna see that in a minute when in aneurysm. So if it's so high that it can stroke you out, because in your brain one of those vessels is pop, then you got a brain bleed and you die. 90% of people who have a massive aneurysm die. Okay, and we get to the hospital fast enough because the brain does not, the skull does not expand. So when that brain starts filling up with blood, the blood has nowhere to go. So it starts compressing on the brain and you die. Okay, if they can get to you in the hospital and pop you a little crack somewhere and let that blood drain out and get that blood out of you and allow the brain to, and then get in there and stitch up that aneurysm, it's a massive surgery. Okay, that's why you just got to take care of yourself. Take care of that old selfish heart because he's taking care of you. Okay? All right. You can have driving pressure of the heart. It could be either called, the hypertension can be either because the heart is pumping too hard or there's resistance in the vascular system. That resistance will be like plaque or calcium deposits inside the artery that's making it narrow. When you have a water hose and you turn it on and just hold it, it's flowing with no problem, right? But if you act like you're a clot or tumor or something and now you make the hole smaller, now the resistance is skeeting out and the resistance inside of the water hose is high now. The pressure is high. Eventually, if you close it completely off, it's going to come out somewhere. It's going to pop somewhere, okay? So the resistance in the vascular system, and you're going to learn what whose law resistance is when we get to gas laws. Talk about resistance and all that. Remember, that's one of the laws. It could be plaque or whatever is causing your resistance. Plaque, fat deposits, all those things. Number 3, the normal blood pressure we said is 120 over 80. The top number is the systolic, which is the contraction of the ventricle, the squeeze of the ventricle, or the depolarization of the ventricle. All of that is the systolic. And then the diastolic is the what of the ventricle? Relaxation. Good. Relaxation. When the ventricle relaxes, that's a pressure inside of a relaxed ventricle, should be about 80. Okay? Should be about 80. That's the repolarization or relaxation of the ventricle. And then you have, of course, your MI, your myocardial infarction. That is the heart attack. See what it says? Coronary artery becomes blocked. Coronary artery becomes blocked. The tissue becomes ischemic, which means it has lack of blood, right? Tissue becomes ischemic. Put an S on becomes. Yep. Tissue becomes ischemic. Then the tissue becomes necrotic. If I don't fix the ischemia, it's going to die. It's got to have that life-giving blood. If they don't give me the blood, it's going to die. Okay? You ever heard of bleeding to death? If you ain't got no blood in you, you're going to die. Not only because you have lack of blood, but lack of pressure. Blood pressure got you. If your blood pressure is 20 over 10, you're going to be dead, right? It has to be at least 120 over 8 is what they want. But too low blood pressure is bad. Too high blood pressure is bad. Okay? Too much of anything, I don't care what it is bad. Even water. Huh? That's not that bad. That's not that bad. Some people run high, right? They run high. Somebody who's been high for 20, 30 years, and then you give them something to get them down to regular, they may start having symptoms, right? Because their body's used to being at that pressure, okay? So it just depends. But you want it to be around 120 over 80. So that tissue in a heart attack, the coronary artery has blocked because of either some fat deposits or some calcium deposits, right? Has blocked that coronary artery from getting blood to the heart, because we said the coronary artery is the red oxygen-rich artery that takes blood away from the heart to the heart, okay? It's still going away from the heart, but it's going to the heart, okay? Tissue, away from the heart, you know, in a sense, but that blood is going not to the body, but to the heart to supply its own blood, okay? If it becomes blocked because of some kind of fat deposit or whatever is causing the blockage, then the tissue that's distal, right? Remember, distal is past, right? Past on downstream. The tissue that's distal to the blockage becomes weak, right? It becomes weak, and if you don't fix it, it will become necrotic, right? The tissue that's distal to the blockage. Make sure you know your terms. Distal means away from, right? Past the blockage. I'm not worried about the tissue in front of the blockage because that's got plenty of blood. But the tissue that's distal to the blockage is going to be the problem because the blood's not getting there, okay? And so that becomes weak and necrotic. You end up having a yang, right? You'll know when you're having one. Feels like somebody standing on your chest. Not necessarily a sharp pain. It's like a pressure, like somebody stepping in your chest. Hmm? Mm-hmm. Mm. Mm. Stepping on you had pressure in your chest. Yeah, you had some kind of reaction to it. Most definitely. All right. Now to the right side of the heart. Cor pulmonale. Cor pulmonale is a general term that we use for right-sided heart failure. Whatever the problem is going on the right side, it's all in a nutshell. It's cor pulmonale. Some people say pulmonale. Some people say pulmonale. Hmm? You write whatever you think you need to write. 1, 2, 3, 4, and 5. You mean? Whatever you need to. I mean, cor pulmonale is right-sided heart failure. It's usually due to pulmonary disease. It's usually because you got some type of lung issue causes right-sided heart failure. Okay? Right-sided hypertrophy. What's hypertrophy mean? Overdeveloped. So if I look at the x-ray, I'm looking at overdeveloped heart on the right side. Like, dang, your right side of his heart is huge, right? Because it's working harder to do what it's supposed to do. Anytime you work a muscle out, it gets what? Bigger. You work your muscles, they get toned, they get bigger. Well, if you see right-sided hypertrophy, you know the person has cor pulmonale. The right side of his heart is bigger than it should be because it's working harder than it should have to, right? Number 4, can cause a left side failure. Now, if the right side heart does not get fixed, it can lead to left-sided heart failure. So if you don't fix it, then it could lead to get worse, and it could lead to left-sided heart failure as well. Okay? And number 5, venous distension may be noted in the neck veins when a patient is sitting at a 30-degree angle. So beside that, put JVD. JVD. Beside, on number 5, it says venous distension may be noted in the neck veins when the patient is laying back at 30-degree angle. That's also known as JVD, which is jugular vein distension. JVD, jugular vein distension. JVD. So look up here. Let me move my mask for a second. If you have a patient, everybody look at me. If you have a patient and you lean that patient at 30 degrees and that neck vein start jumping, that's JVD. They have right-sided heart failure. That's a quick way to know if the patient has right-sided heart failure. Just like I can pinch your finger and see if you got left-side issues with the cardiovascular integrity check, that's checking for the left side because that's to the body. Everything in the body is coming back from that left side. But if I look at that, if I put you back like this and they start this vein, their jugular vein, which is the vein that comes back from the brain to come back through the superior vena cava. The jugular vein attaches to the superior vena cava to get the used up brain blood back into the body, into the heart, right? So when you do that and it starts swelling up, and you can see it, it's either beating bigger or harder or it gets swell up. That's JVD, that's jugular vein distension. Distension means it's bigger. That's why it's important to know your terms. JVD. All right. And we said the congenital abnormalities can cause a right to left shunt, or the blood may be unable to oxygenate because there comes some kind of congenital abnormality. Like the main one is, though, the big one is the transposition of the great vessel. You don't have to know that, but I'm just telling you, a congenital issue, a patient or baby is born with a congenital issue. You all right? Oh, okay. I thought there was a beer. A congenital issue, right? Where the great vessels are transposed, right? So for whatever reason, the pulmonary artery and the aorta are swapped. And when that happens, blood can't oxygenate, can it? If the right ventricle pumps into the aorta, then that blood is going to go back to the what? When it leaves the aorta, it goes where? To the body. So say if this deoxygenated blood, instead of going to the pulmonary artery, is going to the aorta, then you have deoxygenated blood going back to the body again, back to the body again, back to the body again, right? It never can oxygenate because it never goes to the lungs. So whenever that's switched, that's a congenital or genetic defect. Congenital means genetic, right? You're born that way. And doctors can go in and swap it back and help you out, right? The baby can live. You can live after that, okay? So we want that deoxygenated blood to go to the pulmonary artery so it can hit the lungs and pick up that oxygen and come back to the heart, up into the left atrium, down into the left ventricle, and then hit the aorta and go to the body. Okay? All right. A couple more minutes and we'll take a break. So the core pulmonale is the right-sided heart failure, usually due to some type of pulmonary disease. What's the main pulmonary disease that y'all gonna deal with? COPD. COPD. If somebody has COPD, they either have or will have right-sided heart failure. That's a lung. It's coming from a lung disease. Lung diseases cause right-sided heart failure, usually. Okay, usually. So if I say, I'm gonna say a disease, and I want y'all to say left or right. Okay. All right. JVD. Huh? Right. I'm talking about when I say a disease, I want y'all to tell me right or left side heart failure. Okay, you say right or left. CHF. Left side. That's the systemic side. Hypertension. Left side. What about congenital abnormalities? Right side. Right side. What about JVD? Right side. What about COPD? Right side. Right side. Core pulmonale. Right side. Okay? That's how you have to know this. Okay? You got to know what you're dealing with. And again, so Ms. Shepherd, scoot yourself to the edge, or not the edge, but on over, and then you stay on that edge. That way they don't say nothing. That's 6 feet right there. That's perfect. All right. Now, the congenital abnormalities can cause a right to left shunt. Everybody say shunt. Shunt. Say it again. Shunt. A shunt is when you have blood that goes from the right to the left and never picks up oxygen. That's called a right to left shunt. Say shunt. Shunt. Say it again. A shunt, S-H-U-N-T, is when the blood goes from the right side of the heart and makes it to the left side, but never picks up oxygen. Either because it has some kind of transposition of the vessels, or it went to the lungs, but it still didn't pick up no oxygen. Because if my alveoli, which are the air sacs in my lungs, if they close, then it can't pick up. It just goes right by. The blood will go to the alveoli, knock on the door, hey, can I have some blood? Can I have some oxygen? And it says, no, we're closed. So then it says, okay, and it comes back to the left side, never picking up oxygen. That is a right to left shunt. What is that called? A shunt. When blood comes from it makes it from the right side and somehow gets to the left side without picking up oxygen is a shunt. Yeah, because it starts with the right? Starts with the right, goes to the lungs, then to the left, then to the body. But if it goes from the right and makes it all the way back to the left without picking up oxygen, then that is a shunt. Okay? That is a shunt. Congenital abnormalities usually end up with a shunt. Okay? Because, like I said, one of the congenital abnormalities that you want to learn that's kind of real popular or huge is transposition of the great vessels. These are the two great vessels of the heart, the aorta and the pulmonary artery. Those are the two great vessels. If they are flip-flopped from some genetic mess up, DNA mess up, and they're flip-flopped, then you're going to have a shunt because blood is going to come from the right ventricle and go into the aorta instead of the pulmonary artery. So it's going from the right back to the body without picking up oxygen. That is a shunt. Okay? That is a shunt. All right, let's take a break, take a 10-minute break, come back at 2:10, and we will go into the vascular diseases. That's the diseases of the actual vessels, either the artery or the veins. They have diseases as well. Okay, guys, we are now going to take a 10-minute break. I'm going to pause the recording for a 10-minute break. We will come back to vascular diseases. Vascular diseases when we return. Okay, guys, 10-minute break is up. It is now 10 after 2, 11 after 2. We're going to continue on. So we stopped off talking about the diseases, talking about the diseases of the actual heart, left side versus the diseases on the right side. And now we're going to jump into the diseases of the vessels, right? Those actual vessels, the arteries and the veins. Sometimes they are the cause for the problem, okay? I'm going to share my screen again. Back to the lesson plan. All right, vascular diseases. First one is called aneurysm. Everybody say aneurysm. Aneurysm. That is the ballooning out of vessels. If you have it's like a balloon. If you have a vessel that has a lot of pressure in it and it starts to balloon out, that is an aneurysm. Okay, that is an aneurysm. It is ballooning out of the vessels. It weakens the vessel because it stretches it out, like stretch marks, right? Have you ever known somebody has stretch marks after pregnancy? And usually the skin around the stretch marks are kind of weak, right? They're not really firm anymore because the stretching has weakened the actual vessel, okay? And then it can rupture. If it ruptures, it can cause death. Just because you have an aneurysm doesn't necessarily mean that it ruptured, okay? It could be an aneurysm that's just that, an aneurysm. But if it ruptures, you're going to bleed, and you can bleed to death. And it usually happens like in the brain because those vessels in the brain are so small and delicate that that extra pressure and then that ballooning out of that vessel can pop. And if it pops, blood is going to flow in freely into the brain. Okay? So that can cause death. All right. Atherosclerosis. Arteriosclerosis is the hardening of the artery, okay? Hardening of the arteries by calcium. That's arteriosclerosis. Arteriosclerosis is the hardening of the arteries by calcium. Sometimes you have too much calcium or the calcium deposits are not leaving the body like they should. They can cause the arteries to become hard, okay? That's a disease called arteriosclerosis. Hardening of the arteries because of calcium. Number 3 is atherosclerosis. Athero is the buildup of fat deposits in the artery. You have fat deposits in the artery, right? That's atherosclerosis. So an example of atherosclerosis would look like this. Say we have, this is a cross section of the artery, right? Let's just say, doing it like this. Let's just say that's a cross section of the artery, okay? This is looking inside of the artery, okay? Well, this should be all blood coming out of the artery, right? But what if you have a lot of fat in your artery that
Blood flow can't go through.
yeah, see, this is all fat. If this is fat, Now, blood can only come through a little bit of the artery, right? Because you got fat all in your artery because of all of the fatty foods that we might have, all the fried foods and all that to leave that extra grease and fat deposits in your artery. Now you only have a little bit of area for blood to return, okay? So now the blood is only able to come out of this part. You have blocked off so much of that artery. That's called atherosclerosis. One way to remember that is athero and fatso, right? One way I tell people to remember fatso, athero. Okay, athero is fat deposits in the artery. Okay, fat deposits.
Is that a way for them to remove that fat?
I think so, yeah. Your diet. Yeah, so if you have those fat deposits in your artery, as long as you're taking, they tell you high fiber, right? High fiber diet like oatmeal, cereals, stuff like that are good for the heart because they clean the arteries out from the fat deposits. You do not have to be overweight to be suffering from atherosclerosis. Your diet could be just fried food every day, all day. You'll get that. Okay, it's all about your diet. All right. What that does is it narrows the arteries. It narrows them. And so that's increases your chances of an aneurysm because the blood's coming, but it can only get through a small spot. So you're going to put extra resistance prior to the clot, right? So now prior to the clot, everything that's in front of the clot now is getting ready to start ballooning out. If you don't get that fat deposits off of the arteries, and they could be all through the arteries, okay? So it's all about diet in that case. Ischemia. Ischemia is another vascular disease. What did we say ischemia was? Lack of blood to an area, a decreased blood flow to area. That is ischemia. Ischemia is decreased blood flow to an area. That's ischemia, right? It can happen for many things. It can happen for a few reasons. Blood clot. If you have a blood clot in the artery, then there is no blood flow distal to the clot. That means after the clot, there's no blood. So a lack of blood is ischemia. Also, somebody who has a low blood pressure. If your blood pressure is less than 120/80, you could suffer from ischemia, right? If it's really low, that means just the blood's not getting there because there's no enough pressure to push it there, okay? So you can have a problem with low blood pressure. Stand up real quick and fall out, stuff like that. Those are cause of low blood pressure. Somebody, your pressure is low. And so for those who have low blood pressure or hypotension, right? Hypertension is high blood pressure, and hypotension is what? Low blood pressure. So someone who suffers from chronic hypotension, if they stand up too fast, they can pass out because the blood pressure is so low, it doesn't reach the brain fast enough that you try to stand up, okay? And then you get lightheaded or seeing stars and you fall out, okay? Number 5, a hemorrhage. Everybody knows what hemorrhage means, right? Loss of blood. You have a massive amount of uncontrolled bleeding. That's called hemorrhaging. Now, if you get cut on your arm and you bleed, that's not hemorrhaging. Hemorrhaging means you're losing lots of blood, uncontrollable bleeding, like a artery or a vessel became cut inside of your body. If someone slits their wrists or something like that, they're going to hemorrhage to death. If you have a car accident or whatever and you lacerate your liver or you lacerate one of your arteries, you could bleed to death. That's internal bleeding. You could hemorrhage to death. Or for those who have babies, for women who have had a baby, you can hemorrhage if they don't fix the issue, right? If your uterus becomes detached or something like that during birth, you can lose a lot of blood. They have to stop it because you can hemorrhage to death. So hemorrhage is a loss of blood. Usually a ruptured or torn vessel. See that? It's usually because of a ruptured or torn vessel. Then you can go into shock. Shock is acute peripheral circulatory failure. Means you don't circulate. You're not circulating any blood due to the derangement of circulatory control or loss of circulatory fluid. Shock. Shock is the acute, which means automatic, not chronic. A chronic is a long-term thing. Acute is something that happened just now. For some reason it happened just now, right? Acute peripheral circulation. That means you stop circulating. Your blood is no longer circulating through the body because of a massive hemorrhage, right? Or, and let's see the other ones when y'all get through. Ready? All right. Derangement of circulatory control. That means for some reason your body just stops circulating, or a loss of circulating fluid. What is the circulating fluid that goes through your body? Blood. So if you get a loss of blood, you can go into shock. Your body goes on into shock. Right? The body will go into shock because the body wants to live no matter if you do or not. The body wants to live. The body's going to do things to ensure its life, no matter if you try to or not. So if you try to hold your breath, your body will knock you out and breathe because you'll pass out, right? If you can hold it long enough to pass out, that's what the body was doing, passing you out. And now while you passed out, you're going to be breathing. The body's going to breathe. Huh? Now when they drown, you get water in your lungs. And you can't breathe because you can't move anything up in the water. Yeah, up in the water. What I'm saying is if you were to hold your breath and just keep holding your breath, you will eventually pass out. You're probably going to take a breath. I know many people who can hold their breath and pass out, but like a chokehold, if you can't breathe and I got you in a chokehold, eventually you'll pass out because you don't have that oxygen and that blood, that air circulating, right? And so I'm just letting you know that the body wants to live no matter what. So you can't make yourself die just by natural reasons, right? You'll have to really do something outside of natural to do that, right? Your body's going to be trying to get rid of the stuff, trying to fix the problem, right? Yeah. So loss of circulating fluid is going into shock, right? Once your body starts hemorrhaging, the body then goes into shock. Okay, it can be brought. Shock can be brought about by injury, right? A car wreck, and one of your legs gets severed in a car wreck. You're gonna start bleeding out of that leg, right? The body gonna go into shock. You're gonna go into shock and go into a coma because of it. Okay, a lot of times if you have a lot of serious pain, the body will put you into shock so you don't have to deal with the pain. Okay? It's too much pain for you to deal with, so it'll knock you out. All right. Mild shock symptoms would be pallor. What does pallor mean? When somebody has pallor, what is that? Pallor is pale. They look pale or grayish, dusky looking, right? That's pallor. Clamminess, right? Clamminess of the skin. Decreased blood pressure. These are all the things that are marked that show you that they could be going into shock. Their pallor, which means their color is gone, right? They lose their color. They become pale or gray looking, right? Clamminess of the skin. The skin is cold and clammy. Decreased blood pressure. You'll look at their blood pressure and it will be super low, okay? Why would the blood pressure be low in shock? Because what has happened? It's not circulating, but what mainly, your blood pressure is low because you don't have the what? Huh? No. Why would your blood pressure be low?
Blood, you don't have blood.
You ain't got the blood. Hemorrhage. You started to bleed. So the system is a closed system. Once you nick that artery and blood starts going out into the body, you're hemorrhaging. And if you don't have the blood, you don't have blood pressure. Pressure and volume are usually synonymous with each other, okay? If you lose the blood, you're going to lose the pressure. So I said, that's what I told you guys last week. If somebody gets shot and they nick one of those arteries, you drop because of a drop in blood pressure. That's what makes you drop, okay? You lose your blood pressure. So if you're somebody who is hemorrhaging, they're losing blood. And then their body goes into shock, right? And some things to know that they're going into shock, well, I expect to see a low blood pressure because they're hemorrhaging. They're losing the blood, it's running into the street, so their blood pressure is super low because there's no blood to push, okay? Clamminess of the skin, a feeble or rapid pulse rate. The heart has sped up because the blood is losing, the body's not getting the blood, so the heart tries to respond by pumping faster, right? It starts pumping fast. What's going on? Y'all losing blood. Let me pump some more, right? Starts pumping faster, but the pulse, which is the systolic pressure, is weak and feeble because there's hardly no blood there to push. So it's just like a little light thump. Like you feel their pulses and they're weak, feeble, they have pallor, clamminess of the skin, low blood pressure. You can start thinking, hey, he's going into shock, okay? This is how you got the assessment. These are part of your assessments. You go in, you're looking at all these things. You notice pallor. He looks real gray, or she lost her color. Her skin is clammy, right? She has a decrease in blood pressure, feeble and rapid pulse, breathing slower, right? They're going into shock. Those are things you can look at and say automatically in your mind, oh, this person is going into shock. On top of the history of the patient. If you work in ED, you know they had a car wreck or they came in with several gunshots, he's probably hemorrhaging somewhere, okay? This is the reason why he's going into shock.
What if their skin already fried?
Already what?
If it's already fair, like
you can still tell when somebody's pallor. You can tell. It's like they saw a ghost. Don't care how pale you already are, you can tell when there's a difference. Okay. Anyway, number 6, restlessness, anxiety, and sometimes they go unconscious. Those are all some of the symptoms of shock. They go into shock.
What do you do when someone goes to shock?
You got to give them some blood. And hurry up and give them some blood. Find out what's causing the hemorrhage. Put them on a ventilator if you have to, for life support. And probably put them in Trendelenburg to get their blood pressure up. What you're trying to do, when they're going into shock, you're trying to replace the pressure. You got to get that blood pressure up. That's what you got to do. That's the most important thing. Get the blood pressure up and ventilate for them. So their respirations are going to be slow and shallow. They're going on out. So we're going to intubate them, put them on a breathing machine, give them lots of fluids or blood. Okay? Because blood pressure and volume are together. If you don't have the volume there, your pressure is going to be low. Okay? It's going to be low. Number 7, phlebitis. Now we're talking about inflammation of the vein. Phlebitis is not inflammation of the artery. Phlebitis is vein. What is the name of the profession that go around and sticking blood? Phlebotomy. That's where that comes from. The veins. They deal with the veins. Phlebotomists do not get blood from the artery. Whose job is it to get blood from the artery? The respiratory therapist or the physician. The respiratory therapist or the doctor gets blood from the artery. The phlebotomist and the nurse get blood from the veins. Okay? You stick them for an arterial blood gas. You'll learn in the 220 how you stick an artery.
Okay.
Yep, you're going to stick them in their artery.
You really want to stick in the
No, you stick when you get in the hospital and clinicals. Once we have a mannequin over there that has a arm that has arteries on it and pressure and blood in it or colored water, and you'll stick that. You know what? Oh yeah, you're going to be sticking the mannequin, and it's going to have you practice how to stick, what angle to stick, and all that. But when you get in the hospital and clinicals, when you have checked off on ABGs, you'll be trying to practice that in the hospital. So when you've been checked off, you can say, hey, can I get that? If an RT has an ABG, you can ask, hey, can I get that ABG? And they'll watch you. You know, you'll get it, or sometimes you get it, sometimes you don't. It's a very painful stick, though. The artery is a very painful stick. Right? It's one of the most painful sticks is in that artery. Okay? Now, number 7, again, phlebitis. Phlebitis is inflammation. Remember, itis is inflammation. Inflammation of the veins. What about a thrombus? A thrombus is a stationary clot. There's a clot there and it's not moving. A blood clot that's not moving is a thrombus. A clot that is not moving, a blood clot that's stationary, is called a thrombus. But beside that, I want you to write a blood clot that becomes mobile is called an embolus. A clot that becomes mobile, that means a clot that's not stationary. This clot has detached and now it's traveling freely in the blood. That's called an embolus. Embolus. Not S, it's E-M. Embolus. Did you say S-E? Oh, I thought you said S-E. It's where? Oh, okay, good. It's an embolus. That's all right. All right, so a stationary clot is a thrombus, and a mobile clot that has detached and now it's rolling free is a thrombus. That is a thrombus. All right. Now, cardiac inflammation, inflammation of the heart itself. This is almost the end of it. Inflammation of the heart itself. We got layers of the heart. The heart sits in a sac called the what? What is the sac that the heart sits in? The thin film. The heart sits in a little sac. What is that sac called? Pericardium. The pericardium is the sac that the heart sits in. The outer layer of the heart is called the outer layer. Endocardium is the inside. What is the outside of the heart? Epicardium. So the heart sits in a sac. The sac is called the pericardium, right? And then the heart, first layer of the heart, the outside layer of the heart is the epicardium. Then the middle section or the muscle section is called the myocardium. And then the inner side, or inner layer of the heart is the endocardium. You got to know that, guys, and you should know that if you studied that. We had that several times. This weekend should have been a lovely weekend for studying. You should be really up on your game right now. Test tomorrow. The heart sits in a sac called the pericardium. Okay, so if that pericardium becomes inflamed, what is that? If the pericardium becomes inflamed, what is that called? It can lead to that. But what is it? Just being inflamed, simply being inflamed is what? But the pericardium is inflamed. Pericarditis. Itis means inflammation. So if the pericardium becomes inflamed, then it's pericarditis. Inflammation of the pericardium. If the outer layer of the heart becomes inflamed, it's called the what? Epicarditis. Epicarditis. What if the inner layer of the heart becomes inflamed? Endocarditis. And if the muscle part of the heart becomes inflamed, it's myocarditis. I said inside is endocarditis. The inner layer of the heart is the endocardium. Outer is epicardium. The middle or the muscle is the myocardium. Now, if that pericarditis is left untreated, it could lead to cardiac tamponade. Cardiac tamponade. So for instance, this is your heart. All right, that'll be the inner layer. middle layer and outer layer and the whole heart itself sits in a sac so the sac is pericardium, right? That's the sac that the heart sits in. The most inner layer of the heart, what's this called? Endocardium. Then the middle layer of the heart is the myocardium. And then the outer layer of the heart is the what? Pericardium is the sac. Epi. Epicardium. Right? The layers. Those are the layers of the heart. For those online, I'll show it to you here. Those are the layers of the heart. You have the black line is the sac that the heart sits in. That is the pericardium. Then you have the outer layer of the heart, which is the red one, which would be the epicardium. Then the green one is the middle, which is the muscle or myocardium. And then the blue is the inner layer called the endocardium. All right, so if the sac is inflamed, that's pericarditis. If the middle layer is inflamed, that's myocarditis. And if the inner layer is inflamed, that is called what?
Endocarditis.
Endocarditis, good. Let me plug you up, Rayon. I can plug my speaker up. All right. Now, if that pericarditis, if it can lead to what? What does it say it can lead to? Everybody say it together. What's it say? Huh? Cardiac tamponade. What is tamponade? That is blood that makes it into the pericardial sac, causing compression of the heart. So look at this. If this pericardium starts filling up with blood, right? It starts filling up with blood inside that pericardium, that is cardiac tamponade, which is blood inside the pericardium. Right? One way to think about it, when women are on their cycle, they use what?
Tampon.
A tampon to get the blood. That's one way you can remember it.
Also, this is maybe like
If
the tampon of the heart.
Well, not necessarily. It leads to cardiac tamponade if blood gets in there. So if that pericarditis, if that pericardium becomes inflamed, that's pericarditis. If you don't treat it, it can start bleeding and causing blood inside of the sac. Then if there's blood in the sac, it's going to start compressing on the heart, okay? Because the sac does not stretch. So as blood is getting inside of that between the epicardium and the pericardium, blood is getting in there and starting to push on the heart. And you got to get that blood off of there, okay? That's cardiac tamponade, when blood starts to form inside of the pericardium, okay? When blood starts to get inside of the pericardium, That's called cardiac tamponade. Water spill here. All right. All right. Rheumatic fever. Rheumatic fever. Rheumatic fever is another cardiovascular disease. It may damage the valves or the muscle of the heart. Rheumatic fever. If they get rheumatic fever from another country or something like that, you can get rheumatic fever. Rheumatic fever will be it can damage the heart valve or the heart muscles. So not only do the layers of the heart can get inflamed, but if the valves of the heart, what if those those heart valves become inflamed, right? They call that rheumatic fever. Rheumatic fever, and it can decrease the blood flow. If the valve is all jacked up, the blood has to go through those valves, right, in order to get to those chambers. So if the valves are inflamed, then you can have decreased blood can get through those valves, right? So everybody look up here. What if I have rheumatic fever and my pulmonary valve now is inflamed and swollen? Now blood can't get through there, right? So you're gonna have a decrease in blood flow through there if I have rheumatic fever that's causing inflammation of one of my valves, right? Either my tricuspid, my bicuspid, my pulmonary, or my aortic valve. Rheumatic fever can damage one of those valves and become inflamed. When something is inflamed, it's inflamed and it becomes swollen, right? It can become swollen. And so if this valve swell up, then blood can't get through there, okay? And that can cause a lack of blood flow, because if it can't get to the lungs, it can't get back to the heart in order to get to the body, okay? So that can cause a lack of blood flow. Rheumatic fever. And then H, angina pectoralis or pectoris. What's angina mean? No, angina.
Like the squeezing or tightening?
Could be. Angina is pain. Angina is some type of pain. So what is the pectoris? What muscle is the pectoris? No, that's your abdominal muscle. That would be your obliques and your transverse obliques and all that. Your pecs are your man's chest. Your pecs. Yeah. When they move their chest left and right like that, yeah, that's pectoris. They say, oh, he got good big pecs, right? Or pecs, that's what they call them. But the pec muscles, huh? Oh, they don't say that? They say it in the movies. But pecs, right? So your
women
chest.
Got pecs too, pecs. Right?
Huh?
Don't women got pecs too?
Yeah, everybody, yeah. All humans have a pectoris muscles. Yeah, you have chest muscles. That's not defined. You're not defined. So if I have chest pain, it's called angina pectoris. Okay, chest pain. Simply, it's all that's saying is chest pain. Angina pectoris is chest pain. That's why you got to know these words, what angina means, what itis means, what muscles are we talking about when we talk about abdominal muscles, we talk about pectoralis muscles, your sternocleidoid mastoid muscle is what you're going to learn when we get to pulmonary A&P next. Yeah. So number one, angina pectoris is simply pain. Pain is located over the heart, left shoulder, or in the jaw, right? Those are some of the places you can have pain if you're having a heart attack. You can feel it over the heart area. You can feel it in your left shoulder pain or in the jaw. You think it's a toothache and it could actually be a heart attack sign. What causes angina pectoris? Decreased blood supply to the heart by the coronary arteries, which is also what? Decreased blood flow is called what? Huh? Ischemia.
Yeah, ischemia.
It's all right. Ischemia. Ischemia, right there in the notes. Ischemia is lack of blood flow to an area. So that can cause the pain, because once the coronary artery is blocked, then the muscles that are distal to the blockage start to hurt because you don't have blood getting to them, okay? And that can cause angina pectoris, which is simply chest pain. All right, I think this is the last one, congestive heart failure. We already said that's a left side heart issue. Impaired, which congestive heart failure is impaired cardiac pumping. That means this left ventricle, everybody look up here, but y'all can copy that later. The left ventricle is not pumping like it should, right? So if it is not pumping like it should, then that causes congestive heart failure. It starts to back up because the blood that's coming in is not going out like it should. So it starts to back up here, then it starts to back up a little bit here, then back up through here, and it gets back into the lungs, right, around the heart. That is congestive heart failure. Now, these valves are supposed to prevent blood to backflow, but if it's so much blood, it still can get back, okay? It still can get back. That's why those valves are there. They're supposed to be one-way valves that keep the blood from going back and forth. They only should go one direction. But if your valves are jacked up, blood can go back and forth, or if you have a lot of pressure in this left ventricle and you have backed up blood, it can start forcing its way back into the left atrium, back through the pulmonary veins, and show themselves in the around the heart as looks like a hazy look, right? Looks like a lot of fluid sitting around the heart. Okay. Congestive heart failure can be caused by a heart attack, which is myocardial infarction. Ischemic heart disease, that just means you have blockages where you can't get the blood to the heart, which is ischemia. Or cardiomyopathy. Cardiomyopathy. All right, cardiomyopathy. That is the last part of the lesson there. Last part. All right. That has concluded RT 210B, which is cardiac anatomy. We'll now take another 10-minute break, come back and start. We're going to practice over some EKG strips and review. Go back from the top and start reviewing some of the key terms, things that you guys need to know in cardiac anatomy. Then when we get done with reviewing, we'll go over to the lab and do your checkoffs from what you did on Friday.
When is the test?
That's just tomorrow.
Tomorrow?
Yes.
So do we need our 10 cards tomorrow too?
Yeah, you can just take a picture of them. The cards, you can take a picture of them, show me anytime. But we'll discuss that near the end of the class about the, make sure everybody's on the same page about where we're going to be, and because everybody's going to be online tomorrow for tomorrow's class, okay? Because I won't be here. But I will be online proctoring your exams and going over the next section, which is pulmonary A&P. We have to start that. We'll talk about that later. All right, so I'm gonna pause the recording now, guys. Come back at 3 o'clock. Break is over at 3 o'clock. We're gonna now take a break at right now till 3 o'clock. It is 2:50. We'll take a break till 3 o'clock and come back in. We're gonna go over some EKG strips to make sure we understand how to identify basic EKG rhythms, and then we're going to start reviewing for this section, and then around 4:30ish or so, we're going to go over to the lab and complete the checkoffs that you guys did with Mr. Boyd on Friday. So you will go in and check off on heart rate, respiratory rate, and blood pressure. Then after I sign those books off, we will start showing you some EKG stuff. If we make it, we do. If not, we just won't run out. If we run out of time, we can't help it. But we will start showing you the EKG placement Also, you guys should have been studying that in your lab book and where the EKG stickers go, the leads go, and then we'll practice that as well. So I guess he can make up the check off on that one if we don't have time. But we definitely gonna go straight in and check off blood pressure, heart rate, and respiratory rate, because that's something that he said you guys should be ready to do. That we're here on Friday. So that's the check off. I'll see you back at 3 o'clock to start our review. Okay, guys, we are now back from break. It's 3 after 3. We're going to start back with, we have, like I said, we have finished out. So now I'm going to share my screen, and we're going to work on some EKGs, work on a few EKGs before we start reviewing. Share my screen, everybody paying attention, because I'm going to be asking questions. And we'll work on them together. All right, everybody should see my screen now. You see an EKG strip? Y'all see an EKG strip? Y'all see it on the screen? Okay. Huh?
Yeah, we can see it.
Okay, here we go. This is number 1. And these are our choices down here. So let me see if I can make it smaller. Everybody look at that interpretation right now. Look at your EKG, what you're seeing right now. Notice you have this, and don't say anything out loud. Nobody say anything out loud. You're going to put it in the chat. You tell me what you think it is and put it in the chat privately to me. Okay? All right. So look at this. You have a QRS right here, upside down, bizarre looking. And then here we go. Let's look at my arrow. You see we have a PQRST, PQRST, then a QRS out of nowhere, right? It did not follow a P wave. All right. And then again, after that, you go on to another PQRST, PQRST, then another QRS, bizarre looking QRS out of nowhere. What is that called? Put it in the chat. What is this called? Your choices are these. These are your choices. Put it in the chat to me privately what you think that was you just saw. I got one answer. What is that called, guys? We had them all weekend. What is that called? All right, we got to move on. When you have a PQRST, PQRST, and then you have a QRS out of nowhere, it came before a P wave. It's just out of place. That is a premature ventricular complex, or a PVC. Premature ventricular contraction. That's a PVC. That's a PVC. That's correct. Look, it says this is a premature ventricular complex. Look for a rhythm that is irregular with a heart rate that is underlying rate. It says, notice that the P wave is absent. You don't have a P wave before you have the QRS. Whenever you have a QRS out of nowhere, that's a PVC. Okay, PVC. Next strip. What do you think this is? It's just showing the time. It's a 6-second strip, but what is it? And some of these will be something that you probably never seen, because I don't know them all, right? But you just tell me what you think it is, and we'll find out. What is that? I don't think we've even really looked at that one yet. Rihanna, I'm thinking that might be too. Let's click it and see. No, that is a pacemaker single chamber ventricular mode. That's a pacemaker. Somebody who has a pacemaker that's pacing the ventricles, right? It's a pacemaker. So you don't have to worry about that one. Okay, you don't have to worry about that one. I'm only gonna look at the ones that you would probably know. All right, what about this one? What is this one? Look at what you have. You got PQRST, 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 then QRS out of nowhere. QRS out of nowhere again. What is that called? Good, Barbara. Good, Miss Shepherd. What you think, Judith? The QRS out of nowhere. It did not follow a P wave. So it came too soon. Good, Judith. That's another premature ventricular complex. It's a PVC. Another PVC. All right, let's look at another one. Ooh, what did we say that was? Look at that. What did we say that was? Good, Rihanna. Ms. Shepherd, look at it again. Look at that one again. Tell me what you got. Huh? Where you charger? You ain't got the charger?
I got the cord when I got the Bluetooth. I got my cord. I need the Bluetooth.
Here. This is long enough to go to your. You got an iPhone? Just plug it right there. There you go. Yes, I'm asking y'all put it in the chat. Tell me what this is. That's what we're doing right now. You good? That's plugged up straight to the power right there. That's gonna be faster than anything. And it's really long, so you got plenty of room. What is this right here, guys? Judith, yes, you're right, Judith. Good, Miss Shepherd. Barbara got the right answer. Rihanna. What is that? Gabby. Look at it and tell me. It's a sawtooth pattern. Oh, there you go, Gabby. That's right. That's it. The you're looking at the rhythms, and we're trying to figure out what the rhythms are. Good. That's the atrial flutter. Atrial flutter. That's the one that has that sawtooth pattern, right? Looks like a sawtooth. That's a flutter. That is not a deadly rhythm. Atrial rhythms are not deadly. Okay, this is an atrial rhythm when the atria is doing something wrong. Okay, good. That's a flutter. Okay, let's see what this is. What is this? You should be able to tell me what that is without even looking at the answer choices. What is that? Put it in the Rihanna, look at your answer again, Rihanna. It's not a normal sinus rhythm. Hey, Miss Shepherd, that's what it looks like, right? It looks like that. Looks like that. Let's see. What are all the rest of my choices? Okay. All right.
This is
think so? Okay, let's try and see. Ventricular tachycardia, VTAC. Let's see what it is. Yes, VTAC. Monomorphic means they all look the same. Polymorphic VTAC will be, they look the same, but some of them are small, some of them are big, some of them are small. That's polymorphic. They're different sizes, but they all just QRSs. Monomorphic is straight up the same size, VTAC all the way across, okay? QRS, 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 all the same size. That's monomorphic VTAC. Yeah, that's VTAC, all right? But it's more than one. Mono is one, poly is more than one. Yes, yes. Polymorphic or monomorphic. You won't have to answer those monomorphics or polymorphics on your test. You just need to know that's VTAC. Okay? When you see VTAC, I need to be doing what?
CPR.
Calling a code because the patient is coding. Begin CPR. Now, you'll learn a little later. Sometimes you can have VTAC with a pulse. If they have a pulse, you wouldn't start doing it. We'd just give medicine. But for right now, VTAC is a deadly rhythm, so they're probably coding. You need to call a code. Okay?
What's the one where you said if they sitting up there watching TV, but if they sitting up there watching TV, but they saying something else?
Yeah, you just check the leads because leads probably have come off or something. Okay? If you see this, but they're just watching TV, they don't have no symptoms or nothing like that, then don't call code. Check the leads. All right. All right. But right now, all I need you to do is be able to identify EKGs. Okay. All right. Let's look at the next one. What is that one? Now, this is let's see. I can move the time thing here. This is look like a 4-second strip. So I don't know. But it's not asking you the amount of time. It's just asking you what it is. What is that rhythm right there? You see that? What rhythm is that? You got a P, QRST, P, QRST, P, QRST. Let me see. Notice that normal sinus rhythm is not there, right? Because what is it missing? Look at it real close. It's missing something every now and then. What wave is that missing? P wave. That little P wave is there on some of them, but it ain't. So look at my cursor. You see I got a P right here, P, QRST, but the next one is just nothing. It's just a QRST. It's missing the P right there, okay? So that's not a normal sinus rhythm. It's not it looked like it, but you got to look closely. Make sure it has all of its parts. Sinus means it has all of the parts, and it's definitely missing a P wave here and there, okay? Yeah, like right here, there's no P wave at all right here, okay? So you won't see those types. Let's see what that is. I'm going to tell you, junctional pacemaker failure to capture. I'm thinking it might be this pacemaker failure to capture. No, it's a wandering atrial pacemaker. You won't never have to see that, okay? You'll never have to worry about that. A wandering atrial pacemaker. It just means it paces when it wants to and it ain't. And sometimes when it don't want to, it doesn't. Okay, but you won't have to worry about that one. And the one that I know you won't have to worry about, I'm just going to skip them. Let me look at this one first. All right, look at this one. What do you think this one is? By looking at it, it looks like simply a what? Looks like a what? When you have to look, it looks from right off the thing. Yeah, it looks like a. Somebody said a first degree heart block. Some people saying that it looks like a PVC, right? Got a QRS out of nowhere, right? Because that's a T wave there, then a QRS out of nowhere. Now they may be trying to show you something more in depth, but I'm gonna say I think it's it can't be a second degree block because second degree blocks the QRS is dropped. There mean no QRS. You might have a P, QRST, P, QRST, and then P, and you know what I'm saying, then go back into P again, QRST. So that means it just dropped out of nowhere, okay? So it's not a second degree block. And that's not even a choice. Okay, so accelerate jumping on. I don't know. I don't know what they're trying to see. I would have just said a PVC, but I'm sure it ain't PVC again. Yeah, PVC. PVCs are very common.
That's because of the one that dropped down low, right?
Yeah, because it's out of nowhere. It's out of nowhere. So they had the T wave, and then there's no P. It's just a QRS out of nowhere, and it's wide and bizarre. Remember, PVCs or be a QRS that's out of place and it's wide and bizarre looking. It's like, what is that, right? It's not. It could be upside down. It could be super wide, big, out of nowhere. It's simply a PVC. Okay, that is a PVC again. Next strip. What is that? What is that called? Now, does it have all of its parts? That's the first thing I want to know. Does each one have all of its parts? Yes or no? Yes. So a sinus something, right? Look at the R waves. The distance between the R waves, are they uniform all the way?
No.
No. Some of them are wider, some of them are shorter, right?
So it's a block.
Sinus arrhythmia is what I'm thinking. Because it has all of its parts. See, sinus arrhythmia. It's not in rhythm. It's sinus because it has all of its parts. Each one has a P, QRS, and a T. P, QRS, and a T. But if you look at them, some are closer to others than farther from the other, right? You see the R waves? Look at my finger. I mean my cursor. This R, and then how many large boxes is this R from this R? 1, 2, 3, 4. You said 1?
4, 5, 4.
You said, oh, it's a 4. Okay. Yeah. So 1, 2, 3, 4 boxes in between the first set, right? But how many are between the next two? Let's see.
6.
So 1, 2, 3, 4, 5, 6. So that's not in rhythm. So that is a sinus arrhythmia. Okay. It looks normal, but you got to look at it. Make sure they all uniform, right? For it to be normal sinus rhythm, it's got all its parts and everything's the same distance from each other. Okay. You're also gonna have to be looking at this P and the R interval. Remember we said a PR interval? That matters. Okay. And a lot of times when you work in telemetry, they have this little compass with a needle and a pencil on it so they can measure, but you don't have to do all of that, right? We're not going that deep because you have to count those boxes and smaller little boxes. Okay. All right. So that's sinus arrhythmia. Good job. Sinus arrhythmia. Let me see if I want to do this one. Definitely not tachycardia, because it's not fast. Tachycardia means fast.
Bradycardia. Can you go down?
Hold on.
Is it premature arterial cardiac?
I'm not sure. I'm not sure. This is one of those blocks, though. I'm thinking it's dropping the QRS, but I'm not sure. So I'm just gonna say second degree type 2, and we'll see what it say. Yeah, that's a second degree type 2 because it is it's a beat drop, right? They call it I think they call it leaky block, but anyway, it drops a QRS. You have your rhythm, but then it's missing a QRS, right? It's just gone. You're missing a QRS. Then over here, boom, QRS drops on you. So that's a second degree block. You don't have no blocks on your test. Okay, you don't have any blocks on your test. That's a block. We look some more that definitely going to see. Nah, I ain't gonna worry about that one because I think that's a pacemaker one. All right, so that's EKG. Let's see. Some more. Look at this one. What does this look like? What does this look like? Look like you got a P, QRST, P, QRST, P, QRST, P, QRST, P, QRST, huh? Look like normal sinus rhythm. Is that a choice?
No.
Not a choice. So what's close to a normal sinus rhythm? Look at the PR interval. Look at the distance between the P and the R. How many boxes is it supposed to be? How many small boxes should it be? No. Small boxes. Between, look at my cursor. Between the P and the R should be how many? 5 small boxes, right? So how many is that? Just look closely. It's more than 5, though, ain't it? And it's about the same all the way across. It's about the same all the way across, right? Huh? No, not tachycardia. Definitely not that. Look at this. Look at the time, right? How many times it says it is? So that's a 6-second strip. So when you count the R's, it's 1, 2, 3, 4, 5. You want to say 6 right there. 6 R's. That's about 60. So it's not tachycardia, right? But look at it. The PR interval is the problem in this problem. The P and the R should be 5 small boxes apart. So let's look at the P and the R. Look at my cursor. It's kind of hard to see, but 1, 2, 3, 4, 5. It's about 6 or 7 small boxes between the R and the P. Between the R and the P. Look at that. Look at that distance between the P and the R. P and the R. There should only be 5 small boxes, not the big boxes. It should be 5 small boxes apart. So 1, 2, 3, 4, 5, 6, 7, 8. It's about 8 or 9 small boxes apart. So what did I say it was? What kind of block is it when it looks normal, but the PR interval is a little longer all the way through? How much? That's it. Now you're working. Now you're cooking with gas. It looks normal, but you see that PR interval is wider than it should be, right? The PR interval should be no more than 5 small boxes. Look at that. The PR interval is prolonged. That's the explanation that they just gave. The PR interval is prolonged. So anytime the PR interval is longer than it should be, and it's the same all the way through, that's a first-degree block. I told you it can also mimic who? What type of person could have a longer PNR but still be normal? A healthy, well-trained marathon runner. A well-trained athlete may exhibit first-degree block and not necessarily have a block. It's just because they're so healthy. They have trained their heart so well that it can look like that. So this is a first-degree block. Also known, I call it the Houdini, right? Because it kind of mimics. It tricks you. You think it's normal, but it's not. You got to look at the PR interval, okay? The PR interval, which is the P to the R. This is the P wave. This is the R wave. And you count the little bitty boxes in between the two. It should be no more than 5, okay? On this one, it's about 8, and all of them are about 8. So that is a prolonged, means longer than usual, PR interval, which is a first-degree block. Good job. Let me see what this is. What do you think this is? It's a 6-second strip. So look at your choices. Supraventricular tachycardia is really fast. Okay, so what's the heart rate on this one? 1, 2, it's a 6-second strip, so we can count the 1, 2, 3, 4, 5, 6, 7, 8, 9. So that's a heart rate of about what? 90s. Yeah, that's still in the normal range. Does it have all its parts? It does? Okay. Oh, okay. So what do you think it is? Let's see if that's what they say. Good job. Normal sinus rhythm. It looks normal. It has all of its parts. It's not too fast. It's not over 100 or under 60, right? So a sinus something. All of the R waves are spaced out perfectly. The PR interval is where it should be. Normal sinus rhythm. Perfect. Perfect. All right, let's look at this one. This is also a 6-second strip. Okay, got 1, 2, 3, 4, 5, 6 beats in there, so that's about a 60. Let's see, PQRST, PQRST. Oh, dropped the P right there, didn't it? It dropped one right here too, didn't it? All right, so what did we say that was? Wandering atrial pacemaker is what it said last time. Let's see. Yep, that's it. Wandering atrial pacemaker. Because the SA node is the one that's the pacemaker, right? Pacemaker of the heart. Whenever somebody's SA node is messed up, they wear a pacemaker to help fire for that P wave every time, right? And if it's wandering and ain't pacing where it should, you're going to see it drop right there. It's going to see that this person has a pacemaker, but it ain't firing. It's not firing every now and then. So we call it wandering, okay? It's wandering. The P wave is changing shape and size from beat to beat, or it ain't firing at all, okay? Good job. Let's do one more. First thing I would do is look at my PNRs. It looks like they look like they're same side, but this one looks like it's inverted, right?
But we want to try the premature one because it's not that.
No, so like I say, you want some of these that I know you're not going to see. I'm not going to even worry about these. I don't know what's going on right here. It looks like there's something going on right here. It looks like the P wave might have been inverted or something happened right there. Yeah, you can guess. Huh? What you say? I can't hear you. Junctional rhythm? Where you see that at? Oh, accelerated junctional rhythm. Let's see. No, it's premature atrial complex. So a PAC. That's what it is. A PAC is a premature atrial complex, right? It came too soon, right? So if you had a P wave and then another P wave came, that's a premature atrial contraction or complex. Yes, just like a PVC, except it's the P wave instead of the QRS. When the atria contracts, it's a P wave. If the ventricle contracts, it's the QRS. So if the ventricle contracts too soon, that's a PVC. You're going to have a QRS out of place. If the atrial contracts too soon, you're going to see a P wave out of place. Okay? The P waves are the atrial contractions, and the QRSs are the ventricle contractions. So that's simply a PAC. So and it's right here. Look, right here. You had another one that hit too soon, right? You had another one that hit. Look like this is a P wave, then another one hit, and it's inverted as well. Okay, but that's what it is. It's a PAC, premature P wave.
So the P wave is arterial.
Yeah, atrial. Atrial. P wave, because that's what the P wave is. What does the P wave stand for? Atrial contraction or atrial depolarization, or AKA atrial squeeze, right? That is what that is, all right? And the QRS is the ventricle depolarizing or the ventricle squeezing, correct? All right, that's good. So practice up on your EKG strips. Practice up on your EKG strips, and we will now go ahead and go into our little review. Let's go back to the top. And then we can do a review, and then we're going back into the lab to check off. All right. Share my screen. Back to the lesson plan. Matter of fact, let me find the. Yeah, I'm going to explain all that to you. Share. All right, here we go. Lesson plan. All right, going back to the lesson plan, we're just going to quickly go over, just a quick review. The blood. The blood. We said the blood is composed of plasma and cells, right? Plasma in the cells. Blood is about 90% water, 10% solutes. Blood has proteins, which are albumin, which thickens the blood. We have globulin, which is has got antibodies, right? Our antibodies. And then you have fibrogen or prothrombin that are necessary for what? Clotting, right? Blood also has energy molecules, which are what we burn, the lipids, amino acids, and glucose. All that's in the blood. Then what's important is, or very important, the electrolytes. Make sure you guys know these electrolytes. Sodium is 135 to 145 milliequivalents per liter. Chloride, 96 to 105 milliequivalents per liter. Bicarb, 22 to 26 milliequivalents per liter. Potassium, 3.5 to 5 milliequivalents per liter. Calcium, 4.25 to 5.25 milliequivalents per liter. And magnesium, 1.4 to 2.2 milliequivalents per liter. We said calcium, so calcium comes from, you can get calcium from milk, right? So I said a gallon of milk costs about $4.25 to $5.25 a gallon, right? That was how it helped. Then I said potassium, what do you get potassium from? What fruit? Bananas. So about how many bananas come in a bunch when you buy a bunch? About 3.5 to 5. Okay, that's how I remember potassium, okay? But however you want to help you remember, it's cool. All right, but you got to know the electrolytes down pat. You will have questions that ask you what is the normal this or that. You got to know it, okay? The cells that make up our blood are our erythrocytes, which are the red blood cells, and we have the leukocytes, which are the white blood cells. The red blood cells are made where? Where are the red blood cells made? In the bone marrow. How many red blood cells do we have? How many red blood cells? There you go, 4.2 to 6.2 million. All right. What is the protein that carries the oxygen? The hemoglobin. Hemoglobin is what carries the oxygen in the blood. So what's our normal hemoglobin, Deasia? Normal hemoglobin.
12 to 16.
12 to 15 grams. Right there in your notes. 12 to 15 grams is the normal hemoglobin. 12 to 15 grams. Right? You will have a choice to say grams. You might say milliliter. You might say anything. Milliequivalents per liter. You need to know it's grams to make it right. You got to have the right suffix. Then, like the agent said, we have white blood cells. Those are the ones that are 5 to 10,000, right? Normally 5 to 10,000 of the white blood cells, okay? Now, the white blood cells are broken down into subcategories. Eosinophils, they fight, because the leukocytes are the soldiers of the blood. They fight infection or foreign bodies, right? So if we have a allergen or parasite in the body, we expect to see the eosinophils dealing with that. The basophils secrete what? Heparin. Heparin is something that thins the blood. If somebody's on heparin, it's thinning the blood, okay? Mononuclear monocytes, those are the ones that eat foreign material, the phagocytes that eat foreign material in the blood. All right? Lymphocytes. The lymphocytes function as part of the what mechanism? Immune system. Lymphocytes. Remember, you have some lymph nodes in your neck. You have lymph nodes in your underpits. You have lymph nodes in your groin area. Sometimes when people are sick, the doctor will feel your throat to see if your lymph nodes are swollen. That's an immune response. Let us know you have some type of infection. And we said the normal white blood cell count is how much? 5 to 10,000. 5 to 10,000. All right. Then we have the platelets. What are platelets responsible for? Clotting. If you're bleeding, the platelets will go to the cut and block the cut up so you don't bleed to death. All right. Because if you have uncontrollable bleeding, what is that term called? Hemorrhage. So the platelets are there to prevent hemorrhaging. Okay. If you didn't have platelets, you would hemorrhage. I could just punch in your mouth and you'll bleed to death if you don't have any platelets, because you're going to bleed inside and outside and never can stop. No matter how much pressure you put on it, if you don't have platelets, you can't the blood won't stop the bleeding. All right. Now, don't forget the 3 types of fluid we have in the body. All right. The blood makes up the intravascular fluid. All right. That's the fluid that's inside the vessels. But we also have some fluid in 2 other places. Interstitial is the fluid where? In between the cells. Intracellular is the fluid where? Within the cell or inside the cell. Good. Now, speaking of inside the cell, which electrolytes are found inside the cell? Great numbers. Which electrolyte is found inside the cells? Potassium. And which one is on the outside that's wanting to come in? Sodium. And when the sodium creeps in, that causes depolarization or contraction of the heart, right? Good. All right. Purpose of the blood. Blood has several purposes, like 5. Transport respiratory gases, circulate the defenses, takes nutrients to the cells, removes waste from the cells, is responsible for clotting, and what? Electrolytes. That's the purpose of the blood. They may ask you what are all of them. They may ask you just give me 2 or just give me 1. They may say which one of these is not a purpose of the blood. All right? Or all of these are except, stuff like that. Make sure you're able to answer those type of questions. All right? Some of our laboratory numbers. We said we have 4.2 to 6.2 million red blood cells. We already covered that. We already said the white blood count is 5 to 10,000. All right? If you want to go back and look at the actual individual cells of the leukocytes, then you can say neutrophils was 40 to 75%, lymphocytes are 20 to 45, and so on. Okay, I don't ask you questions like that. I don't ask you questions like that. All right, hematocrit. Hematocrit is the percentage of packed cell volume. How do you find hematocrit? What I say was the formula to find the hematocrit. What's times 3? Hemoglobin times 3 is the hematocrit. Hemoglobin times 3, which is a percent. All right, the answer is in percent. Don't say grams, because that would be incorrect. So somebody who has a hemoglobin of 10, what is their percent hematocrit? 30%. 30%, okay? The normal hemoglobin is about 12 to 15. So you're looking at a hematocrit that should be within those levels. So 15 times 3 is what? 45%, which is normal, right? A hematocrit of 45% would be normal, right? All right, so that's a hematocrit. Here it is again, hemoglobin, they just show it again. 12 to 15, y'all. 12 to 15 for hemoglobin. All right, what about the finger puncture? What do we say the finger pinch check was for?
Make sure everything is circulating.
Cardiovascular integrity. We do the finger pinch check to see if your cardiovascular, which is which side?
Right.
The systemic or left side is doing what it's doing, because everything in the blood in the hands comes from the left side of the heart. So we look for the cardiovascular integrity through the pinch check, the integrity of the systemic blood system, which is the left side of the heart. Okay? If any of these diseases are present on the left side, you may have a problem with the finger pinch check. Okay? When we do the finger pinch check, we're checking the cardiovascular integrity, mainly of the left side of the circulation, which is the systemic side of the heart. All right? We talked about the heart, the location. Where is the location of the heart? Okay, so what about to the sternum? Where is it as in relationship to the sternum?
Below.
Posterior or behind, or you can even say retro, right? Behind the sternum. What is its location to the diaphragm? Superior means above the diaphragm. And which side does it hang to? To the left. Layers of the heart. The sac around the heart is the pericardium. Outer wall of the heart, epicardium. The inner wall of the heart and the muscle part of the heart, okay, inflammation of any one of these layers is just itis on the end of it, right? Itis. Which one of those inflammations can cause cardiac tamponade? Inflammation of which one of those layers can cause cardiac tamponade? Pericardium. So pericarditis can lead to what? Pericarditis leads to cardiac tamponade. Cardiac tamponade, which means it's just blood filling inside the sac, compressing on the heart. That's cardiac tamponade. All right? The 4 chambers and the 4 valves of the heart. We should know that down packed, right? We should know that down packed. Here's the heart, all right? Here's the heart. So I'm gonna pass it to Deasia. Deasia, I want you to put your finger on the superior vena cava. Good, pass it. Miss Shepherd, put your finger on the aorta. Good, pass it. Miss Judith, show us the tricuspid valve. The tricuspid valve. The tricuspid valve. Open them up. Where's the tricuspid valve? Right here. This is the tricuspid valve. Okay? The left atrium and the left ventricle is the tricuspid valve. Miss Taylor, show us the bicuspid. Good. Bicuspid valve is the valve between the right atrium and the right ventricle. That's the bicuspid valve. Good. All right. Gabby, show us the pulmonary veins. Pulmonary veins. Blood returns from the lungs via the pulmonary veins. All right. Show me the pulmonary veins. Pulmonary veins. All right, so make sure you guys study over the blood flow of the heart and the chambers and valves of the heart. Good job. All right, good job. So we have the superior and inferior vena cava. Then we have the right ventricle, tricuspid valve. Right atrium, right here, right atrium, tricuspid valve, right ventricle. We have the pulmonic valve, pulmonary artery. Then we have the lungs, comes back to the heart via the pulmonary veins, right? Here and here, pulmonary veins. And they go into the left atrium, right? Left atria, down through the bicuspid valve into the left ventricle, then through the aortic valve into the aorta, and then to the body. That is the blood flow through the heart. Make sure you know which side is which. The right side is the pulmonary circulation, left side is the systemic circulation. All right. What type of vessels do we have in the body? There are 2 types of vessels, or 3 types. 2 mains are arteries and veins. Arteries do what? Away from the heart, and veins. All right. Remember, arteries are oxygen-rich blood. Veins are deoxygenated blood, except for which ones? Which 2 veins is this opposite in? I said arteries are blood-rich, oxygen-rich blood in the artery. And veins are deoxygenated blood, except for pulmonary arteries, because it's deoxygenated, right? And the pulmonary veins are oxygenated. Just because of where they are, that's the only exception. But they still do what we said. Artery is still taking blood away from the heart into the lungs, and veins are still take blood to the heart, but in this case from the lungs, so it will be oxygenated. Okay, that's the only exception. Capillaries are just the little vessels in between artery and vein. They intertwine in what's called capillaries. This is where the gas exchange takes place in the tissue level, is in the capillaries, right? Capillaries. When we go into pulmonary A&P, you guys are going to learn what gas exchange happens inside the lungs, which is external respiration. You will then learn where that is, okay? Here's the circulation. We already said this is circulation of blood through the heart. Pulse, pulse sites. What do we take the pulse at when we check a pulse? What are some places we can check? Radial, show me brachial. Brachial, show me carotid. Carotid, what about femoral? In your groin. Femoral is in your groin, right? What about dorsalis pedis? That's ulnar. On top of your foot is dorsalis pedis, and then ulnar is under the pinky. Ulnar is under pinky, okay? Radial on this side, ulnar on this side. Good. What do we take the blood pressure? Over which artery did we take the blood pressure? Brachial artery. What equipment do we use for blood pressure? Sphygmomanometer and the excellent. You learned the procedure already. Cardiac stimulation. The electrical pathway through the heart starts with the what? SA node, which is known as the pacemaker of the heart. It fires at a rate of what? 60 to 100, which is normal heart rate. 60 to 100 is the normal heart rate. Then it fires to the AV node. The AV node is what? The backup pacemaker, right? And it fires at a rate of 40 to 60. After it leaves the AV node, it goes to the bundle of His and then divides into the what? Good. Then down to the, and then that's the one that shocks the muscle to make it contract, right? All right. Terminology, systole, AKA contraction, also AKA squeeze, AKA depolarization. Good. What about diastole, AKA relaxation, AKA relax or repolarization. Good. Repolarization. The words tachy means fast, brady means slow. So any heart rate greater than 100 is tachycardia. Heart rate less than 60 is bradycardia. All right. On the cellular level, Judith told us that inside of the cell is rich with electrolyte potassium, right? On extracellular, which means outside the cell, is full of sodium, right? Well, basically, the sodium creeps into the cell and reacts with the potassium and causes depolarization. When that depolarization happens, the heart squeezes, the cell squeezes and pumps the sodium back out of the cell. Once the sodium is back outside of the cell can now relax or repolarize. That's what happens. Bottom line. Okay? That's what happens. All right. Almost done. Basic EKG waves. We know we have a P wave, is atrial depolarization or squeeze, right? QRS is the what? Ventricle depolarization. And the T wave is the repolarization of the ventricle. Now some people say, well, what about the atrial? Does not the atrial have to repolarize, right? Yes. Atrial repolarization would be there, but the QRS is so big, it's buried. So you can't see the atrial repolarization because the QRS is so big, okay? So that would have been a U, I think. QRSTU or something like that, okay? That would have been the U, but you don't see it because it's buried under the QRS, okay? So those are the basic parts of the EKG, all right? Anything that we said is sinus has all of its what? Parts. The rhythm will start at the SA node and go down the regular way for it to be sinus. So most times you'll see a normal sinus rhythm. Anytime you have all the parts, but the heart rate is less than 60, that's sinus bradycardia. Anytime you have all of the parts, but it's faster than 100 is sinus. Okay, what if it's the R and R's are not the same? You have all its parts, but it's not in rhythm. That's sinus arrhythmia. All right, good job. You have some atrial rhythms that are not deadly, and you have some ventriculars that some are deadly. Atrial rhythms are abnormal P wave, right? If the P wave is just, look at me. If the P wave is just quivering, then that's atrial what? Fibrillation, A-fib. When it's just, if the atria is sharp, 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 then that's what? Atrial flutter. Looks like a knife pattern, right? That's a flutter when it's sharp, sharp, sharp P waves, okay? If the P waves are just kind of shaking, then that's atrial fibrillation, okay? Neither one of those are life-threatening, okay? All right? You have some junctional nodal rhythms, often inverted P wave. When a P wave is inverted, instead of it being on top, it's inverted. That will be a junctional rhythm, okay? A junctional rhythm. All right. Now we have some ventricular rhythms or arrhythmias, all right? PVCs, what happens? That when you have a QRS out of place and it does not follow a pattern, but it is if a QRS that does not follow a P wave, right? Because you're supposed to have P, QRST, P, QRST. But if I have a QRS before the P wave, it's a PVC. Premature ventricular contraction. It contracted too soon. Didn't want to wait on the P wave. It said, I want to do it now. Came too soon. That's a PVC. All right? PVCs, the way they look, they're usually large and wide and bizarre looking, right? They look different. They come early in the cycle and not following the P wave. Okay? Now, there can be some times that they're dangerous. Make sure you highlight this or you understand this part because you have a question about when they become dangerous. They are dangerous when there are multiple configurations of them. If you have more than 1 in 10 beats, or they land near the T wave. If they land right by the T wave, then that's when they become dangerous. All right? Not life-threatening, but they can become dangerous if one of those 3 things is present. All right? What about VTAC? We're going to finish this up, then we'll take a 20-minute break, and then we'll finish up with the lab. What about VTAC? VTAC, when you see nothing but what? QRSs. Nothing but QRS, 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 QRS. There's no P, there's no T. It's just straight up QRS, QRS, QRS. All right? They appear to be on a series of PVCs. They are dangerous and life-threatening. Okay? They are life-threatening. In this case, that's one of the deadly rhythms. It can be a deadly rhythm. Eventually, PVCs will turn into what? I'm sorry. Eventually, the VTAC will turn into V fibrillation. VTAC will end up being V-fib, which definitely is a life-threatening arrhythmia. When you V-fib, you must, when I say that, call the code and shock the patient, right? So shocking, the other word for shocking the patient is what? Defibrillation. So V-fib, you D-fib. That's how you remember that. If I see V-fib, I know I got a D-fib. And the only time I'm going to shock them is after I done called the code, right? You don't just go in a room shocking nobody. Okay, you have to call the code. They have cardiac arrest. And another thing is this. V-fib is exactly the same as cardiac standstill, which is what? Flatline is what? What's that called? Flatline is called what? Asystole. No contraction. A means no. Systole means contraction. So V-fib is physiologically the same as asystole. Make sure you write that down. V-fib is physiologically the same as asystole. Okay? V-fib is physiologically the same as asystole because there's no contraction of the ventricle. So if there's no contraction of the ventricle and it's just kind of fluttering or it's just kind of fibrillating or shaking, twitching, that's the same. You might as well be asystole, okay? That's the exact same thing as cardiac standstill or asystole. You will see that on your test. You must defib, which is defibrillate. That means shock. We shock with a defibrillator. They bring the crash cart in the room. It has a defibrillator on it, which has paddles or pads or whatever they use to shock you. Gonna say charging, just like you do CPR, and it shocks you. It's called defibrillation. Okay, so if they're in defib, you definitely must. If they're in VFib, you must defib them. Okay, shock them. Life ending. VFib is the exact same as what? It's life ending, physiologically the same as what? Cardiac standstill, which is asystole. Good, same thing. I mean, the heart might as well just be sitting there, just like this heart right now. This is asystole. Do you see it beating? It's asystole. VFib is the same thing as just asystole, just sitting there. It's not pushing any blood anywhere. Okay? Cardiac standstill. CPR must be initiated and shock them. Asystole, of course, is flatline, right? If you're looking at flatline, that's asystole. Now, the trigger one is the EMD. This is another deadly rhythm. EMD, electrical mechanical dissonance, which means you have electrical activity, but there's no pulse. So if you look at the EKG, it looks like a beautiful, normal sinus rhythm, but the patient is over there with his tongue hanging out his mouth and dead. All right, so if you see a normal rhythm, you must still check your patient. Because if he's over there and you try to call his name and he doesn't respond, but you see a normal rhythm up there, go check his pulse. Because the telemetry don't know he don't have a pulse. All they see the beats, right? So you need to go and check that pulse. If you don't have a pulse, you hit the cold button and get on the chest. Okay? Cold button and start CPR immediately because he is dead. Okay? He has a rhythm, electrical activity, but there's no contraction. Okay? That's called electrical mechanical dissonance, also known as what? PEA, which is what? That means electrical activity without a what? Pulse. There's no pulse. Same thing. Same thing.
How do you pick out the sound?
Just tell them they need to leave, step out. Sometimes they do, sometimes they don't.
Sometimes they do stuff in front of them.
Yeah, you be doing something in front of the family all the time. Yeah.
Even when they
Well, they have policies as far as ages are concerned, but if somebody goes into a call, they'll usher the family out. They'll usher you out the room. You don't have time to worry about that. You know, you start doing CPR, they're gonna be all in looking. You just, somebody will tell them to leave. All right. Now, finally, the cardiovascular diseases, which we hit on today. Make sure you go back and study those. We don't have to go back through all of these again. We just went over those. Okay, that's in the lesson. That's in the recorded lecture. Everything is complete. You have the PowerPoint in the lecture. You have those different little things you can look at. You have your notes and your reading. Make sure you do your reading. That's very important. You have questions that come from the reading that you might not have got in the lecture. So make sure you do your reading and all of the different books that it tells you to look at it. All right?
What chapter?
It's in the syllabus. I don't know right off the top of my head. You have to look at the
18.
syllabus. More than one chapter though. Look in your syllabus. It will tell you exactly the chapters and which books this information comes out of. Okay, for RT210B, it tells you all of the chapters that you need to look at. Okay, and the books you need to look at them in. All right. Like I said, we just went over those diseases that we just talked about. They're there for you. This is here for you. We're now going to stop the recording and go into the lab. Now, before I do lab, highlight for tomorrow. Tomorrow, you will all log in on Zoom, okay? Nobody will be up here on campus tomorrow. I'll be out of town. So when you come in tomorrow at 1, I'll give you time to come in. You will I'll answer any little few questions you might have before the test, and then you will clear your area out, cut your camera on, and I will proctor your test. You will take your test, and then we will jump straight into pulmonary A&P.
So we don't gotta come tomorrow.
No. You're gonna be at home, wherever you're gonna be, but you gotta log in because this is where I need to see everybody's workspace and you to take your exam. You're gonna take your exam, and after the exam, we're gonna jump straight into pulmonary A&P, the lesson plan for RT210C. Email you what? Yeah, I'll do that. Okay. I'll email you guys a note-taking guide so you can print it off from home or whatever. But I will, if it's not already in there, I think it's already in there. But I'll email it to you just the same. It's all good. Yeah, so tomorrow, nobody's on campus tomorrow. Everybody will log in at 1 o'clock to take the exam. Okay, if you can't make the lecture all day, that's your prerogative because it will be recorded. But you do have to be logged in to take the exam. I need to see you, your workspace, to take your exam. After the exam, like I said, we will jump straight into pulmonary A&P and move right on like we've been moving on. Okay, make sure you go back and study RT210A when you study B because you can see A at any time. A lot of terminology is in A. Right? You may see some kilogram stuff in this test. Make sure you go back and look at that. Make sure you go back and always go to the past and keep up with those things. You have to use all of them for what you do next. Nothing that we do is we're done with that. We can forget about that and go on to the next thing. None of it's like that with respiratory. It all builds on each other, the foundation, okay? All right, so like I said, I'm going to stop the recording. We're going to go over to the laboratory and do the blood pressure, heart rate, and respiratory rate lab that you guys did. Mr. Boyd said you guys should be ready to just check off on that. Once we check you off on that, depending on the time, I will go over the EKG leads because that's part of the lab as well. Okay, the EKG.
I got a question.
Yes.
Okay, I was there Friday, but I'm not there today. So what about my check?
Up the lab.
So I'm gonna have to redo all that stuff I did on Friday.
You're gonna have to check off on it Friday. Or whenever you get here, you're gonna have to check off. Everybody is checking. I'm not gonna go over today and show y'all how to do blood pressure again. He did all of that with you guys Friday. Today you're gonna go in and say, when I say, okay, the first two, I'm gonna watch the first two do it, and I'm gonna check you off. That's it. I'm not showing anything, none of that. You guys should be ready to do that. Now the EKG stuff I will show. Okay, I'll go over where the stickers go and all that on the body. Because he didn't get over that. But he did do the heart rate, respiratory rate, and blood pressure with you guys. So we're going to go over there and check out. Now, those who have the blood pressure cuffs, I hope you brought them back. All right? And we're going to do it like that. So if you're not here today, but you were here Friday, that means you're going to have to get with Mr. Boyd and find out when you can come in and check off on what we're checking off today. That's going to be totally on the student to contact the lab instructor to schedule a time for your makeup. Okay? Question? Okay. All right, so I'm going to stop the recording now. We're going to take a 20-minute break and go head over to the lab. Yeah, we're getting ready to take a 20-minute break. Let's see. Yeah, 4:25 in the lab. Meet me at 4:25 in the lab to check you off on what you did Friday, okay, and begin the EKG part. Other than that, I will not be logging back into Zoom. So those who are here on Zoom, you are done for the day. If you're not here, you're done for the day. You can log out. We do have homework scheduled for today in Canvas, so make sure you get the homework assignment that says homework that's due on the 3rd. You'll do that by midnight tonight for your attendance today. You have to do that and turn that in by midnight. All right. Other than that, you're free to go, and we're gonna go over to the lab. This, like I said, this is recorded. It will be added to the Canvas as a live lecture for 8/3/2020.